I'd like to welcome everyone once again to this wonderful conversation we're getting ready to have. And I'm so excited to hear from these great panelists that we have lined up for you. We have some of the best minds in Northeast Ohio and Ohio on this topic tonight to enlighten us and have a real discussion, as we're calling it, real talk about racism as a public health crisis. Now, before we get started, we want to share that closed captioning is available for all of our audience. Simply click on that CC icon you see along the bottom of your Zoom screen. A live transcript should begin immediately. We also want to remind everyone that this Real Talk event is being recorded, and we will email all the registrants tomorrow, and it'll be available for you there on your email, or you can go to the website, LWV.org. That's realtalklwv.org. So Real Talk is a diversity, equity, and inclusion program hosted by 4 League of Women groups in Northeast Ohio: Akron, Hudson, Greater Cleveland, and Kent, in strong partnership with the Akron NAACP, ideastream, WKSU, and the Freedom Bloc. Now, Real Talk candidly addresses the issues of inequity, disparity, discrimination, and racism that impact public health, education, criminal justice, housing and employment, and democracy. It's real talk for real action. And I love that part, the real action part. And at the end of our conversation, we want you to think about what you can do, what action you can take. So this is going to be a conversation, but we're going to talk about action at the end. So that's a little teaser for you about what's to come. Real Talk is able to host these critically important community discussions because of outstanding partners. Well, let me first introduce myself. I'm Marlene Harris-Taylor. I said that at the top, but I'm the managing producer at ideastream, WCPN. Some people know us as that. We're the NPR affiliate, but we're also WVIZ PBS. We have a health unit there where we have 2 reporters and a community engagement specialist, and I'm the manager of that team. And as that team, we are focusing for the next 2 years on this topic of racism as a public health crisis. We know that it's very important for people in the community to know about health disparities. We've heard about all kinds of health disparities over we have reams and reams of data on health disparities. But one of the things that we're interested in talking about now is solutions. And I think everybody has kind of come to that same conclusion at one time, that we need to start focusing on solutions versus just the problem. And I believe that's why we've had so many public entities, nonprofits declaring racism as a public health crisis. And I went to a training recently that was hosted by Third Space in Cleveland. It was a diversity and equity training, DEI, as people are calling it right now. And there was a metaphor that was shared about fish and a lake. And some of you may have heard this before, but if you're walking along a lakeshore and you see a dead fish or 2 dead fish, you might say to yourself, what's wrong with those fish? But if you continue to walk along that lakeshore for a few days and you see more dead fish, and the dead fish just keep piling up, at some point you're going to turn your attention away from the fish and say, what's going on in this lake that's killing these fish? And I believe that's what we're here to talk about tonight, about what's going on in the lake that's creating these health disparities in the community, in minority communities, across our community, across the state, and across the nation, really, right? So, we're so lucky to have these wonderful partners who've helped make this night possible. It's been critically important that we have these community discussions, and we would not be able to do it without special thanks to Judy Hill, who's the president of the Akron NAACP. We'll hear from her in a little bit, but we also want to thank the incredible producers and talent at Sound of Ideas at ideastream and ideastream as a whole, and the dedicated news team at WKSU. And a warm thanks to all of our esteemed partners we'll be hearing from tonight. We really appreciate our partners making this conversation possible. Now, we'll begin the evening with a broad look at how racism impacts public health across the state and how racism perpetuates these social determinants of health. We've heard so much about those, the things outside of, say, going to the doctor's office that impact people's health. Feel free to drop any questions for the panel in the chat and the Q&A box, and we'll be sure to peek in on the chat box throughout the evening. Michael Barron will be adding important information and links in the chat box during each segment. As mentioned, the Akron NAACP is a strong partner of the Real Talk program, but the NAACP itself is a long-standing side-by-side partner of the League of Women Voters across the country and in Ohio, particularly in the spaces of democracy, voters' rights, and fair district maps. Judy Hill has been the prolific front-facing leader of the Akron NAACP for all issues impacting civil rights, criminal justice, health, education, employment, and housing. Judy, thank you so much. We really appreciate it.
Thank you very much for having me for this Real Talk conversation. I am really very, very humbled and proud to be asked to give some opening remarks. But I want to definitely go back and also, again, thank the partners on this call, because it's because of this partnership that we can possibly move this needle and make a difference. I think the time is now to address the systemic racism that plagues our nation. After 2020, we all saw, the whole world saw, how racism affects not just our social being, our health, our happiness, our safety, and our lives. We were just reminded of it again in Minnesota with Dante Wright and what happened to them. So if you don't believe that racism plays a part in what we've been experiencing and how racism is a public health crisis, it costs someone their life. You can't get any more of a health crisis than that. I've never known why we feel it's okay to have someone use their weapon in a way that takes someone's life, and you mistake a weapon for your taser. I just don't understand it. But I believe that racism has some underpinnings in all of everything that we do, including some of the police brutality, but all of it impacts our health. Because when people feel safe, when people feel that they have access, when people feel connected to a community, that changes the narrative, and people can live that American dream as we are so to have. I think it's time for a collective like the individuals that are at the table today to not just stir the pot, but change the ingredients so we can all enjoy the aroma of the American dream, and that this land is our land and it's for all of us. So again, I want to thank the collective for allowing me to give some remarks in the beginning, but also for having the Real Talk. And I hope those in the audience are ready to roll up their sleeve and do something besides just be here today. We've heard, we've seen. Now, what are you going to do to make the changes that need to occur? I know I'm in for the long haul. I hope they will be too. Thank you.
Thank you, Judy, for those beautiful opening remarks. And now let's get down to some real talk. We're going to turn to our panel now. Our panelists this evening are David Maywhoor, Executive Director of the Ohio Public Health Association, Dr. Charles Maudlin, a world-renowned kidney transplant surgeon and urologist. He's the founder of the Minority Men's Health Center and the annual fair that was held at Cleveland Clinic. Iris Harvey is President and CEO of Planned Parenthood of Greater Ohio. Yvonka Marie Hall is the Executive Director of the Northeast Ohio Black Health Coalition. And Dr. Ronald Hickman is the Endowment Chair and Associate Dean for Research at the Francis Payne Bolton School of Nursing at Case Western Reserve University. We're so lucky to have a panel of this caliber here with us this evening. And we're going to get started with David Maywhoor, and he's going to talk about public health across Ohio, David, I'm so happy to have you kicking things off with that broad look across the state.
Well, thank you, Marlene, and I'm glad to be here. I'm really also honored to be able to present the Ohio Public Health Association's statement on racism as a public health crisis. So I'll get started. Racism is a system of structuring opportunity and assigning value based on the social interpretation of how one looks and unfairly advantages other individuals and communities, and it saps the strength of the whole society through the waste of human resources. That's a quote from Camara Phyllis Jones, who is the APHA past president. The Ohio Public Health Association recognizes that racism exists and that it has diminished life and health outcomes for communities of color. Catastrophic infant and mortality rates, escalating incidence of heart disease, diabetes, and stroke, social determinants of health such as proximity to environmental pollutants, substandard school, low-wage employment opportunities, and a disproportionate share of the incarcerated population are just some of the challenges a person of color must contend with while simply striving to be successful. Racism is a driving force of the social economic determinants of health disparities. Now we're given daily examples of how our broken healthcare system, coupled with those pre-existing conditions, are exacerbating the impact of COVID-19 throughout our historically underrepresented neighborhoods, which are oftentimes communities of color. As the voice of public health in Ohio, OPHA will not be silent in declaring racism as a public health crisis. Dr. Martin Luther King warned us years ago, our lives begin to end the day we become silent about things that matter. The life of OPHA will not end and we will not be silent. The roots of racism are woven deep into the fabric of America's history and our everyday life. The genesis was steeped in injustice when the very first free African person was abducted in the early 1600s and brought to this country to become the property of mostly rich and predominantly white landowners. Families were separated, homes, languages were erased, religious practices were obliterated, and for 265 years, African peoples were bought and sold as expendable property, and personhood was eliminated. When emancipation finally came, it was followed by another 100 years of Jim Crow laws, redlining, urban renewal, deficient education, healthcare atrocities, the literal burning of Black-owned business districts and towns, leveling of whole, vibrant and flourishing communities, turning them into highways, and then the flooding of Black communities with illicit drugs. That flood of drugs resulted in treatment of addicted individuals as if they were immoral, low-life failures deserving incarceration, rather than from the perspective of an illness deserving of treatment and rehabilitation, as is now afforded to rapidly growing white addicted individuals. Recognizing these truths in the building of our country's institutional racism requires that we are not silent, that we speak about this history, and that we act to end the economic, education, criminal justice, and healthcare apartheid, which has been crafted and supported by public policy. Public health promotes and protects the health of people in the communities where they live, learn, work, and play. The social determinants of health have a 60 to 70% impact on one's health, and racism is a major driver of the disparities that exist in the social determinants of health. In consideration of these issues, public health must work to eliminate racism and to promote and protect the health of people of color, as it is a roadblock to their achieving the optimal state of health and living, harming, as we have seen, killing individuals and their families and eliminating all they might have contributed to this world. So one might ask, what is OPHA doing? Our considerations for changing these dynamics must include ways to address all the facets of the social determinants of health, housing, education, healthcare, criminal justice, environment, and nutrition. Racism must be addressed simultaneously. So OPHA is working to pass laws which would require that all proposed legislation and state-based rules be reviewed with a health and equity lens. This process would determine if new policies would have negative, positive, or neutral impact on communities of color and other underserved communities. We developed a tool which can be used to analyze legislation and proposed rules and policies. This tool can be used by Ohio legislature and local policy-making bodies as well. We hosted a two-part Policy Institute webinar series on racism as a public health crisis, and we will continue to build on this series with future offerings. We humbly acknowledge that the public health system is not immune to the biases and racial structures that we name in this statement. OPHA must have its own house in order for us to effectively continue our advocacy against racial justice. Thus, our first action will be to conduct an internal organizational assessment of our current operating policies and procedures and bylaws. OPHA will work with the consultant after the assessment is completed to develop an action plan with tangible, measurable steps to correct identified deficiencies. We'll also work to continue with the contractor to assist OPHA Governing Council in developing an external-facing blueprint of policy and action steps. Both of these plans will be disseminated to OPHA member and other partner organizations for OPHA leadership accountability. This is our commitment to recognizing and addressing the reality that racism is a public health crisis. Thank you for inviting me to be here tonight, and I look forward to the questions that are coming for us.
Thank you, David, for making that strong declaration about racism as a public health crisis. So now we move to Dr. Charles Maudlin, who's going to talk about racism and chronic illnesses. Dr. Maudlin?
Yeah, thanks for having me. I'm proud to be here, and it's nice to see you again, Marlene, and work with you. I know we've worked together on several projects in the past. This is a very important topic that we're here to speak on tonight. I had some slides. Are those slides up? If not, it's okay. Okay, yes. So, you know, it's very important when we talk about health and wellness that we realize, and as clinicians, a lot of times we focus on just the physical aspects of health. But it's important that we realize that back in 1947, the World Health Organization defined health as a state of complete, not only physical, but mental and social well-being as well. And as clinicians and healthcare providers, we need to remember that when we're intervening with communities and the patients that we serve. Can I have the next slide? The demographics of America, of the United States, are rapidly changing. You know, back in 1970, only about 12% of the U.S. population was considered to be minority. That's African American, Hispanic, Latino, Asian Americans, Pacific Islanders, and Alaskan natives. But as you see, as time moves on, marches on, you can see that the percentage of minorities in the nation is actually rapidly increasing. In fact, actually by the year 2050, if not before, minorities are going to become majority percentage of the population. And so what happens to the quote unquote minority percentage of the population actually has an ever increasing implication in terms of the overall health of the nation. Next slide, please. So with the diversification and changing demographics of America, there comes an increasing crisis, and that crisis is represented by what we call racial disparities, especially in racial and ethnic minority populations. Next slide. And so there are several examples of health disparities, but the National Institute on Minority Health and Health Disparities actually defines health disparity as a higher incidence or prevalence of disease. And when we look at minority populations, in almost every category, African Americans are number one in terms of the incidence and prevalence of disease and chronic disease states, an earlier onset or faster progression of disease, poorer daily functioning or quality of life, premature or excessive mortality. These healthcare disparities actually contribute to African Americans having on average compared to their white counterparts about a 5 to 8 year shorter life expectancy from birth. And again, they include, there's a greater global burden, and that's the definition of what is considered to be a healthcare disparity. Next slide, please. So these are just some examples. Again, there are numerous more examples that I could speak on this evening, but for example, you look at African-American populations compared to Caucasian American populations, a 44% more death rate from cancer each year, higher incidence of the four most common cancers, breast, lung, prostate, and colorectal cancer, 30% higher death rate from heart disease, 180% higher death from stroke, a 2 times greater recurrent stroke rate, and the list goes on and on. Higher incidence of diabetes, hypertension, and other conditions. Next slide. Again, this just shows some of these statistics. Even our young individuals are having a greater incidence of diabetes. I talked about a greater incidence of heart disease. Cardiomyopathy and congestive heart failure actually has even a different pathogenesis in African Americans in general compared to their white counterparts. It's more likely due to a untreated long-term hypertension. There's a greater incidence of kidney disease. You know, the greatest, most prevalent causes of kidney disease are diabetes and high blood pressure, hypertension. High blood pressure, hypertension, we call it a silent killer because you can have significant high blood pressure and not even know that you have it. Untreated elevated high blood pressure leads to peripheral vascular disease, heart disease, stroke, kidney failure, and other conditions. I'm a urologist. One of the things that I focus in on is the diagnosis and treatment of prostate cancer. Twice the incidence, twice the death rate is observed in Black men with prostate cancer as a consequence of prostate cancer. Next slide, please. So again, cardiovascular disease is the leading cause of death in all Americans, but even more so in African Americans. And what the literature and research has shown, we need more study on this, that race and ethnicity of a particular patient can actually influence that patient's chance of receiving a specific medical procedure or recommendation for a medical procedure or treatment by their caregivers, by their physicians. We need to study more why this is, and this is even when you control for socioeconomic status, insurance status. We still see, for example, that African Americans who present to emergency rooms and hospitals with signs and symptoms of suggestive of a coronary a myocardial infarction or angina are less likely to be referred to receive a diagnostic test, coronary angiography, and 1/3 less likely to even be referred for cardiovascular bypass surgery. This has something to do with physician bias. Again, more needs to be looked into this. Next slide. So next slide, please. So yeah, I talked about the greater incidence of stroke in African-American populations. And it actually even gets down to the fact that African Americans, there are different types of strokes, cerebral infarctions, hemorrhagic strokes. African Americans have a greater incidence of hemorrhagic strokes, whereas whites have a greater incidence of ischemic strokes. This goes down to the fact that race in medicine, even though there's not a definite definition of what race in medicine is important. It's got to be used responsibly, but race can be used as a surrogate marker whereby certain individuals or a group of individuals may have a higher incidence of a particular medical condition or disease state. Next slide. So again, I talked about the higher incidence of cancer in African Americans. Next slide. And again, it's very important that we adapt and continue to screen for a lot of these conditions. A lot of African Americans, other minorities, typically have not had the same type of access to healthcare compared to their white counterparts. But we've seen that since we've opened up opportunities and access for screenings, we see that there are the lower death rates related to colorectal cancer, lung cancer, prostate cancer. And this is all great. Even though there's a lower death rate, there's still a gap, a greater incidence of death rate in African Americans compared to white Americans. Next slide. So again, look at the startling statistics of diabetes in Ohio, especially 2 to 3 times greater the incidence of diabetes in Blacks versus whites, as well as the rest of the country. Next slide. I've focused, dedicated a lot of my career to performing kidney transplants. There's evidence actually in the medical literature that African Americans are, even though they are equally medically suitable, are less likely to be referred for a kidney transplant evaluation, less likely to complete the evaluation, be listed on the kidney transplant list, less likely to receive a transplant, wait 2 to 4 times as long to receive a transplant. And a lot of this has to do with lack of referral, physician bias. Also, many minorities, African American populations don't know that transplantation is an option for them. And so we as clinicians need to empower individuals, help educate them about how they can better improve their health, and we need to promote opportunities for better access to care. Next slide. Again, life expectancy in African Americans compared to their Caucasian American counterparts over the several decades has always lagged behind. Next slide. So this is actually very telling, and this is data from Cuyahoga County, and there's similar data across the United States, but this data shows that where you live determines how long you live. And so, for example, if you live in the Huff neighborhood or central inner city Cleveland, your life expectancy in some instances can be 20 years or shorter compared to if you live in one of the outer ring suburbs, one of the more affluent suburbs. And a lot of this is related to what we call the social determinants of health, which we heard about from our first presenter. The social determinants of health relate to poverty level, less access to healthcare, less access to healthy foods, unemployment, living in unhealthy environmental conditions, and things of that nature. And we as healthcare providers need to understand that we have a responsibility to try to address these. As you heard previously, a lot of this is related to historical redlining, which forced African Americans, other minority populations to live in certain locations. Next slide, please. So there are various reasons for the healthcare disparities, education, historical factors, distrust of the healthcare system, racism, bias on the part of healthcare providers, social determinants of health, lack of diversity in the healthcare workforce. There is a minor component to a genetic biologic component that contributes to these healthcare disparities. But by and large, healthcare providers and the public, we need to become more aware of the contributing causes to these healthcare disparities, because we need to find solutions to each one of the contributing factors so that we can put an end to these healthcare disparities and tackle the social determinants of health that are contributing to these healthcare disparities. Next slide. So next slide. So I'm going to close up here. There's evidence in the public health literature, American Journal of Public Health. They did a study, it's dated, it needs to be repeated, but during a 10-year period back in the 90s, they demonstrated that if African Americans could have received the same quality of care as their white counterparts, more than or close to 900,000 deaths could have been prevented and averted. It says 5 times as many lives can be saved by correcting the disparities than in developing new treatments. So with that, I'm going to go ahead and close, and I look forward to hearing the comments from the rest of the panel.
Dr. Modlin, thank you so much for, basically taking us on that journey through health disparities, and you gave us a lot to think about there. And I want you to know, Dr. Modlin, some questions came in while you were talking, and I wanted to remind everyone that we welcome your questions. Please go ahead and put those questions in the chat. And after the panel, each panelist has had a time to talk. We are going to have a Q&A session later, so please share your questions as they come to you as we're going through this forum tonight. So next, we're going to hear from Iris Harvey, who's the president and CEO of Planned Parenthood of Greater Ohio. And Iris is going to take a deep dive on women's and infant health. Take it away, Iris.
Hi, thank you, Marlene. Thanks for the invitation, the League of Women Voters and WCPN, and all of the wonderful speakers here. I feel very honored to join you. At Planned Parenthood, we strive to create a world where reproductive and sexual rights are basic human rights, and where access to healthcare does not depend on who you are, wherever any individual lives, and that everyone has the opportunity to choose their own path to a healthy and meaningful life. Here in Greater Ohio, we have 17 health centers that are across the state that serve our patients. We serve over 50,000 patients and 80,000 patient visits. And our healthcare system is designed to serve patients who have difficulty accessing healthcare. Over half of our health centers are in health professional shortage areas, rural or medically underserved areas. So we provide basic, primary, and comprehensive preventive health care to many who otherwise would not have a place to turn to, especially for their family planning care. We're a safety net provider. More than nearly 40% of our patients are people of color, with most of them identifying as people of color, as African American. And half of our patients live at incomes at or below 150% of the federal poverty level, which is $26,000 for a family of four. So it's a real struggle. And nearly 40% of our patients rely on Medicaid to access health care. And so for many people, Planned Parenthood is their only source of care, making our health centers a irreplaceable component of the state's health system. And as experts in reproductive health care, Planned Parenthood centers often provide family planning services that other safety net providers do not offer. And so again, we get to that point of access. Where do you have the access? And what does that access provide you? For many women, Planned Parenthood health centers are also their primary source of reproductive health care. And research has shown that 4 in 10 patients rely on family planning clinics as their only recent or their most recent source for healthcare. And increasingly, we're building our healthcare practice to serve the needs of our patients across their life cycle. So we recognize that while family planning may bring many of our patients to us, we know that most women will spend nearly 30 years of their reproductive life trying not to get pregnant. And so therefore, there is a large number of opportunities to address wellness and to ensure that they have the access to care. So we recognize that experiences with racism across the lifespan of Black and Brown patients often lead to an accumulation of toxic shock and stress and trauma, which usually and ultimately can affect a person's physical health. So caring for our patients includes before and after they're pregnant, as well as providing healthcare related to planning a healthy pregnancy. So we pride ourselves on facilitating our patients' healthy pregnancy with referrals to culturally competent prenatal care providers, including Black doulas and midwives. Again, making sure that the whole pathway to good health is looking again at the issues of racism and making sure that people of color, especially Black women, are being competently provided with unbiased care. So we believe that protecting the health of Black women means creating a world where racism at all levels is eliminated. Healthcare is treated as the innate human right that it is, and that high quality care is accessible to all. So caring for maternal health does not begin with when a person gets pregnant, and it doesn't end when a pregnancy is over. Black women deserve to be seen, embraced, and supported throughout their life and at all stages of pregnancy if they choose to be pregnant. Planned Parenthood provides educational and essential reproductive health services, including our cancer screenings, STI testing and treatment, birth control, abortion, wellness checks, gender affirming care, and chronic care assessment, and more to protect the health of Black women, and increasingly also other people of color, but also men and other identities. Many of our patients who become pregnant come to us for screenings for diabetes, for high blood pressure, depression, substance abuse, and environmental exposures, as well as concern about weight management, smoking cessation support, and to receive vaccinations, both the flu and HPV, and also for preconception counseling. So I would be remiss if I didn't mention that Black motherhood and abortion are not mutually exclusive. Supporting Black mothers requires supporting their rights and their ability to make their own decisions about pregnancy and about motherhood. So in improving the health of Black women requires systematic change throughout the entire healthcare system, as well as other systems as education and immigration, with a focus on equity. We must build a future in which everyone, regardless of their income, their immigration status, their gender identity, their sexual orientation, their abilities or race, can access expert, compassionate healthcare without bias or judgment. And Black women deserve the support and resources they need to have healthy lives, and when pregnant, to have safe pregnancies and births, access to compassionate, unbiased healthcare providers, and support persons throughout a lifetime that encourages good health outcomes and including pregnancies. So as a reproductive health movement spelled out, Black women deserve the freedom to decide if and when they want children, and to be able to raise their children in safe, healthy environments beyond birth and postpartum period. Black women must be able to access the social, economic, and environmental resources necessary to be happy and successful individuals, and also to build strong families and communities. So Planned Parenthood will continue to trust and support Black women. We think that they know best about their health care. We don't believe just because we are the health professionals, we know more. We may know how to provide the care, but they know their bodies better than anyone. And so we are in this fight for health equality. We're proud to follow the lead of, for instance, Black Mamas Matter Alliance and Black women across the country who are bringing awareness to maternal health rights and issues and the injustice that many Black mothers are experience. And so we remain committed to using our voice to advocate at the state and national level to enact policies that protect our sisters' health and safety. Thank you.
Thank you so much, Iris. And Iris, while you were speaking, a comment came in saying, thank you, Planned Parenthood, for all that you do. I thought you would appreciate that.
Thank you.
So, and lots of questions are coming in as well, and we appreciate that. So please keep those questions coming in for our Q&A segment. So we're moving on to a topic that many people don't think about when it comes to health disparities. We're going to talk about mental health in the Black community. Yvonka Marie Hall is here. She's the Executive Director of the Northeast Ohio Black Health Coalition. Yvonka.
Hi there, how are you all?
Hey, we're good. Looking forward to hearing your presentation. I know
Well,
you.
thank you for thank you for having me. So what I want to talk about is the Northeast Ohio Black Health Coalition first. So the Northeast Ohio Black Health Coalition is a social justice organization that was created to address the impact of racism on African-American disparities, including policy inequities, historical trauma, food insecurity, research, behavioral health, and addiction, health promotion by working to empower, educate, and advocate for the community. We've been doing this work since 2011, and we have a policy director, we have a research and evaluation director, I have a behavioral health and addiction specialist that are part of my team. And so that has been an important piece in us continuing to do the work. One of the things that we talk about is the issues. So the issues is that, you know, that everybody has talked about prior to me is that African Americans are plagued with persistent race-based disparities that have existed for centuries. And this has impacted their health compared to their white counterparts as a whole. What is more so important is this whole concept about race. You know, one of the things that we do understand is that race began as an issue around language. So race was defined by language. And then in the 17th century, it became about how you looked because of the enslavement issue. And so that whole thing around racism started then too. So the belief that race is a fundamental determinant of human traits and capabilities, and that racial differences produce an inherent superiority of a particular race. We also have to understand that when we're talking about the African American experience, whether we're talking about mental health or physical health, we have to understand that 87% of the African American experience is our experience here from 1619 to 1965. And then the time from 1965 to now only represents about 13% of our time here in the United States. And so when we're looking at this setting around what do we know about African Americans, we have to make sure that we're taking into account that 87%. um we have to look at the whole thing around historical experimentation and the whole mental aspect of what happened with our ancestors in starting 1830s is some of the first things that we started to note at the Baltimore resurrectionists, which is about 70 years. 1845, we talked about Tuskegee, we talked about the Lyle Station, Henrietta Lacks, the radiation study that was done on African American children, the lead paint studies, and then also the forced sterilization of African American women in the South. That's one of the things that Fannie Lou Hamer talked about a lot. She actually coined the term Mississippi appendectomy. Um, and so the thing about African Americans is there were two times in our experience here that our health status actually improved. So there were two times between 1865 and 1872 was that post-war Reconstruction. It's directly linked to the establishment of the Freedmen's Bureau. And so that Freedmen's Bureau allowed us to have Black medical schools, hospitals, and clinics that were throughout the South. The Freedmen's Bureau saved the African American community from extinction. And then the time between 1965 and 1975, which is the Civil Rights Movement. The Civil Rights Act outlawed racial discrimination in government funded health settings. And so what we looked at is Medicaid and Medicare, hospital desegregation, integrated staff and patients, community and neighborhood health centers, which gave people a place to go with folks that look like them. So when they were going in for treatment, they saw people who and engaged with people who they knew from their communities who looked like them and who they saw at the grocery store and at the schools and at the other things that were going on in their communities. And so those things were important. Now, what has been happening lately around our current trauma is that Dr. Maudlin hinted on it, but since 2016, African American life expectancy has dropped 2.7 years. So our life expectancy has dropped from 75 years to 72 years. And then when we look at this whole COVID, when we look at what COVID has done, we have to understand that African Americans are about 2.9 times the rate of whites to be hospitalized, but about 1.9 times more likely to die. And we also know the mental health impact on COVID. Of COVID on different communities. And so one of the things that we did was we wanted to make sure that in our organization that we put together support groups for African Americans who either had COVID, had experienced loss from COVID, um, or are having are long haulers. So one of the things that people didn't know is that I have COVID. I'm actually a long hauler. This is my 65th day out. One of my uncles had COVID. Like 10 of us had it together. Because someone came from out of town to visit my grandmother. And so my uncle had to have his arm amputated as a direct result of his experience with COVID. And he has mental health issues. And so he wasn't able to articulate to us what was going on with him. And so we also have to look at anti-racism in hospital settings and make sure that that is part of the training and curriculum for our hospitals, and looking at how they're treating African Americans that are coming in for different procedures or that may be concerned about their health status. Um, the other thing is around policies. So what's important for us is to understand that within this whole talk about structural racism, we have to examine our systems and understand that the policies of these systems are built on racism, whether we're talking about our healthcare system, our food systems, education, environment, our policies, just regular everyday policies, transportation, housing, employment, and economics. Those things are all important to the African American community. The Kerner Commission put it this way with their release of their report on February the 29th, 1968. Dr. King was still alive then, and Dr. King pronounced the report a physician's warning for approaching death with a prescription for life. So on February the 29th, 1968, he was saying, look, we could use this report as an impetus to make sure that the needs of the community are addressed. And 2 months later, he was gone. Why is this important to us? This is important because in 2002, the National Medical Association also released a report called Racism in Medicine and Health Parity for African Americans is the Slave Health Deficit. So it talked about what has been going on physically, mentally, economically with people who were enslaved from that point to now. And it also said that racism in medicine has operated at institutional, intellectual, policy, and personal levels, and that it's deeply ingrained in the fabric of the United States culture. To eliminate persistent race-based disparities, the U.S. must implement dramatic changes in policies that hide the structure, functioning, and financing of the healthcare system and must direct efforts to produce a system and a workforce that is culturally competent and culturally proficient, is what my team says, in dealing with African Americans. Um, the Kerner Commission report also went on to say that what white America has never fully understood, but what the Negro can never forget, is that white society is deeply implicated in the ghetto. In other words, white institutions created it, white institutions maintain it, and white society condones it. The Northeast Ohio Black Health Coalition produced a report that was actually released yesterday. It is called the African American Rescue Plan. It's part of the CARES Act for how we want to see the $541 million that the city of Cleveland is going to receive from that to be used to address the unique needs of the African American community. And what we did was we broke it out in education, employment, housing, and health. But in our health piece, these are the things that we asked for. These are the things that came up the most out of the 200 and some people that are part of that health committee. Anti-racism training in healthcare, policing, education, housing, banking, and employment should be our #1 goal to improve African American health outcomes. Drug policy decriminalization, including the allocation of funds for addiction treatments, recovery housing, and supplies to protect the health of our community. This includes addressing the impact of mentholated and flavored tobacco, vaping, and e-cigarettes on the community. Create policies to eliminate systemic racism in the foster care system that disproportionately impacts African American children. This must include funding for kinship care for families that are not foster care certified and custody has not been legally changed. Health career-based curricula beginning in elementary schools to help increase our culturally proficient workforce and end the cradle to prison pipeline that has ravaged the African American community. And finally, since racism is a public health emergency, we must ensure that the city, policing, housing, health, and education systems represent the best interests of the community by creating policies and practices that address the social determinants of health and make sure that they're not punitive in nature or practice. Thank you.
Yvonka, thank you so much. See, I promised before that you were going to be interesting and you delivered. Yvonka, that's great to see your group being so proactive too, coming up with those concrete steps, concrete actions you'd like to see happen. So let's move on to our next panelist, and this is our last panel presentation, and then we'll go on to Q&A after this. Dr. Ronald Hickman, he's the Endowment Chair and Associate Dean for Research at the Francis Payne Bolton School of Nursing at Case Western Reserve University. And he's going to talk about the nursing profession and education. And I'm so glad to see nursing profession represented here tonight, because so often we hear about doctors, but nurses are the ones right there in the room with you. Right, Dr. Hickman?
Absolutely, Marlene. And thank you for that introduction. And also thanks I'm very want to express my gratitude to the League of Women Voters and IdeaStream for this opportunity to share my perspectives as a nurse researcher and clinician. Already this evening, we've heard compelling narratives and seen evidence on how racism is a public health crisis. It impacts the healthcare access, and quality of care among Black and Brown racialized populations in Northeast Ohio and certainly well beyond. To each of my esteemed colleagues who've presented tonight, thank you for your illuminating perspectives and highlighting the structural and social determinants that certainly perpetuate health inequity among racial and ethnic minorities in our communities. Over the last year, our nation has certainly witnessed the symptoms of structural racism, the disproportionate use of lethal force on unarmed Black men, such as George Floyd and most recently Daunte Wright, by police officers. And we've seen the differential impact of the COVID-19 pandemic on communities of color. These are two stark examples of how structural racism, this combination of our social biases, racial discrimination, becomes embedded into our social, economic, political, legal, and even our healthcare systems, resulting in social injustices and health inequities. These symptoms have brought to our attention that racism has a structural basis, and confronting racism in the context of health and healthcare requires not only changing individuals' attitudes, but also transforming and eliminating policies and practice that result in unequal treatment and care. For me, the events of the last year cannot be unseen and certainly have been a call to action to dismantle structural racism. As frontline providers, nurses have joined the chorus as advocates to challenge healthcare administrators, policymakers, governmental officials to denounce policies and practice that perpetuate inequities. However, modern healthcare is rooted in scientific racism and eugenic movements that are currently impeding our nation's ability to combat the COVID-19 pandemic and vaccination uptake. It's time for nursing, medicine, and public health professionals to turn the lens of evaluation on ourselves in order to effectively address structural racism and its broad impact on the health of racial minorities. Now, oftentimes in these conversations, nurses are not brought to these venues, but nurses comprise of the largest sector of healthcare workforce, with more than 20 million nurses worldwide and over 4 million nurses practicing right here in the United States. And in Northeast Ohio, there's roughly 185,000 nurses working in hospitals and community settings all throughout our communities. Yet nationally and locally, the nursing workforce is certainly not representative of the population it serves. Based on 2019 data from the Ohio Board of Nursing, only 11% of Ohio nurses identified themselves as a underrepresented racial minority, which is much lower than the state population of racial minorities, which is estimated at 21% in that same year. The national nursing workforce racial trends are not much better than what we're doing right here in Ohio. Over a decade, we've seen modest increases in racial diversity in the nursing workforce. And even though it's increasing, it's certainly not keeping pace with the changing racial demography of our nation. So I bring this to the point because in 2003, the Institute of Medicine published a landmark report, and that report's titled Unequal Treatment, Confronting Racial and Ethnic Disparities in Healthcare. And the committee of this report recommended strategies to achieve a racially representative workforce of healthcare providers, and also provide clear evidence on how a racially and representative workforce of nurses and other healthcare providers would substantially reduce health disparities, address unequal treatment, and most importantly, counter the effects of structural and institutional racism. Yet for nearly 20 years after the release of this landmark report, there has only been a modest improvement, in particular the workforce of nurses, and the same could be said for other healthcare professionals. So why has there been such little progress towards diversifying the nursing workforce? The answer to this question is certainly complex, and there are a number of factors to consider. However, like our colleagues in medicine, nurses must also come to grip with its own history of structural racism. It's my personal and maybe even a controversial stance that one of the contributing factors to nursing's limited progression and diversifying its workforce is linked to the founder of modern nursing, Florence Nightingale. Recently, author Natalie Stake-Dossett, a nurse historian, provided a historical review of Nightingale's perspective on colonialism and racism, and her unwillingness to educate Black and Indigenous women as nurses. And for many years in the US, long after her death, women of color and men were often denied opportunities to train as nurses. Now, certainly federal policies such as Title IX has helped to advance the diversity of the nursing workforce, but the nursing profession and discipline has not fully come to grips with the lingering impact of Nightingale's perspective on race. So at the moment, nurses on the front lines and faculty in schools of nursing are calling out structural and institutional racism, which is an important first step, but it's simply not enough. Deeply examining our admission and scholarship policies and increasing our efforts to create and sustain inclusive learning and work environments are needed if we're going to ever achieve a diverse nursing workforce. As a profession, there's a need to provide new academic programs that can transition racial minorities working as nursing assistants or licensed practical nurses, LPNs, to registered nurses. In fact, if we can consider these novel or innovative academic programs, we might be able to move the needle slightly on the diversity of the nursing workforce and also promote economic equity at the same time. There's also a growing movement in academic nursing to implement anti-racist curricula and examine textbooks for racial and implicit bias that can contribute to health disparities and inequities among racial minorities. In my opinion, all of these solutions and many more should be considered if we are going to actually have a palpable increase in the diversity of the nursing workforce and reduce health inequities. Now, historically, nurses have been instrumental in advancing our nation's public health and leading social change. And one example of a nurse change agent and community activist is the well-known public health nurse, Lillian Wald. Wald is a pioneer in public health nursing who saw firsthand consequences of how poverty and other social determinants of health affected immigrants and people of color living on the Lower East Side of New York City. Inspired to positively influence the health of persons who were socially and medically disenfranchised, Wald established innovative models of providing nursing care in unusual places like public schools and championed social reform for immigrants, women, and African Americans. And today, nurses continue to advocate for those who are seldom seated at the tables where decisions are made. Nurses are leading programs in communities to decrease gang and gun violence, working to find effective local solutions to reverse the harmful effects of environmental pollution. And of the subject matter of today's conversation are pressing the issue and addressing policies to counter the lingering and adverse effects of racism and discrimination in all of its forms on the health of all Americans. So as we celebrate as a nation and as a community 2021 as the International Year of the Nurse, I'm reminded that as a nurse leader, the future of our profession, its impact on health and well-being of persons is squarely centered on how we serve our communities. Nurses play a vital role in our communities to not only better health, but lead social change. Our work in communities, rural and urban, must continue. Nurse researchers are in the prime position to answer questions on how social mechanisms such as structural and institutional racism impact health behaviors, and lead research to test novel interventions to effectively address social and structural factors that influence health disparities at the individual and certainly at the population levels. The disproportionate and negative effects of the COVID-19 pandemic on the communities of color is but another reminder of the persistent needs of these communities for renovated models of care in which nurses are well positioned to lead. So to all of you who are listening today or watching, who are inspired to dismantle structural racism and improve the health of racial minorities, stay encouraged, continue to lead by example, and I thank you.
Thank you so much, Dr. Hickman. So that's some real talk there, taking on Florence Nightingale. You said it was controversial. So now it's time for our Q&A segment. And I have to tell you, we have some wonderful questions that have already come in from folks who are watching. We have questions that we have prepared, and we have about 20 minutes to take on these questions. So I'm going to get right to it. And to the panelists, I don't want everybody to feel like everyone has to answer every question, so we can get through these. But if you have something that you really want to say, absolutely, just jump right on in. So you might want to all unmute yourself, so it'll be kind of easy to jump in on these questions. But let's start off with talking about our big topic of the night, which is racism as a public health crisis, right? There's this sweeping movement going on across the country, large and small, declaring racism as a public health crisis. We just had the CDC declaring it last week, right? So what is all this accomplishing? What is this? Do you feel like this declaration from the CDC is going to move this movement forward? What can we do? How can this have an impact, declaring racism as a public health crisis at that national level, where we're hearing at the state level and through all these agencies? Who wants to jump in on that one?
Can I just start first? So this is Yvonka. So I have talked about this a number of times, because just declaring racism as a public health crisis and not making sure that policies, not punitive policies, but policies that help uplift the communities, are put in place to go along with that public health announcement, it doesn't change anything. And so what we see is we have all of these voices saying, racism is a public health crisis. And they're like, oh, it's a public health crisis, but there's nothing, everything else falls silent. And so we have to make sure that our cities, our counties, our states, and our federal government have policies in place to help uplift the communities that are disproportionately impacted by racist practices.
So we need more than just talk, is what you're saying. Anybody else want to weigh in on that?
So Marlene, I'd love to jump in and just build on Yvonka's comments. And I'd say certainly we definitely need policy reform. And as a scientist, I'd say we need the evidence. How do we dismantle structural racism and sort of a population and system levels approaches? We certainly need the evidence. So I think the CDC weighing in on racism as a public health crisis has certainly activated agencies like the National Institutes of Health to put forward new initiatives to really make this a research priority and provide evidence, scientific evidence, that can certainly help to inform our policymakers' decision-making.
And another part of that question is this something that's widely accepted in the medical community, that racism is a public health crisis in the medical field? Why or why not? Dr. Modlin, you want to weigh in on that?
Yeah, so historically, whenever in the medical profession, whenever anybody would talk about health disparities, health equity, racism, it's a taboo subject. Over the past decade or so, I think clinicians, physicians, medical researchers are starting to understand that when somebody talks about health disparities, you're not pointing the finger at them, as individuals. And so, I see that medicine, the medical profession, is moving in the right direction. The CDC coming out and proclaiming that racism is a public health crisis, I think it is a very important step. However, they didn't go far enough, because they didn't actually explain the pathophysiology in terms of how racism contributes to poorer health outcomes. And I've seen a number of TV commentators over the last several days, for example, disputing this, denying this, trying to push back on the fact that racism is a public health crisis. Now, we learn in medical school and physiology class that when somebody is undergoing chronic stress, and racism actually is a source of chronic stress, whether it's overt racism or microaggressions that people experience over their lifetimes. The physiology, the biologic basis for this is it sets off a cascade of hormonal reactions in your body. It affects your hypothalamus, which is a section of your brain, which sends a signal to your pituitary. These hormones then cause an increase in your adrenaline, your cortisone, which is a stress steroid, which can actually induce diabetes, high blood pressure. So there is a pathophysiologic, biologic basis whereby chronic stress, which is a result of racism, can actually cause physical manifestations of disease, which then can translate into, like Yvonka was talking about, mental health responses. There are research studies showing that there are structural and molecular alterations in the brains of individuals who are chronically stressed. So I think the CDC needs to go further and actually explain the biological pathophysiological mechanism, because a lot of people are pushing back and trying to deny that this is actually a real phenomenon.
Now we have a question from one of the people viewing that I'd like to share. It's from Sharon Broussard. She said, "There's so many things to do. What are the first steps should we take to be anti-racist, and not just the Ohio Department of Health? And how do we do things that with this conservative white legislature that we have in Columbus?" Maybe David, maybe you can jump in on that. Like, we're talking about the CDC didn't go far enough and we need some action. So what could be a first step, she wants to know?
Well, one of the first steps that can be taken is to get to know your own legislator. There have been 2 concurrent resolutions submitted to the Senate and to the House declaring racism as a public health crisis. And those have been languishing because the leadership in both the House and the Senate have not moved them forward. And so we really need people to, that's House Concurrent Resolution 4 and Senate Concurrent Resolution 6. So we need House 6 and Senate 4. So we need people to make contact with their legislators to talk with them about something that is in their hands. It's not as if you have to create it. The language is there, and it is really important for people to take that first step. So that's a first step that people can take.
And I thank you so much, David, for that. And Iris, there was a question that came in when you were talking about health disparities in the general population. Black women, is it the same for Black women as it is for Black men, or is it worse, or is it, are there clear differences there? Iris, you're muted.
I think certainly when we look at Black women and maternal and infant mortality by gender, there are differences between the white population. Probably our doctors could speak a lot more to the fact that we're seeing chronic illnesses, chronic diseases that are impacting both Black women and Black men, again, at a rate that is much higher than we see in the white population. I think some of the issues that have a great deal of impact on women that we need to think about is to the point of 2 of our speakers who said we actually need to put policy in place. That is where you get to the structural changes. And for me, I think when I think of women, policies that need to be considered would be for one thing, we all need a living wage, but certainly women who are increasingly the breadwinners in their family need a living wage, not just a minimum wage. We need a national family leave policy. Women are usually the ones who are taking care of the family, no matter who is in the household. We need to close the gender wage gap between men and women, because if you don't have the economic capabilities to take care of your family, there are a whole degree of health concerns because of social determinants of health. We need affordable childcare. If you are taking care of your family and you're making the decision between whether you leave your child with a poor caretaker or you go to a job, very often people make the right decision to stay with their children, but then that puts them into a bigger economic penalty. And I still think that we need a national health care program. I think the Affordable Care went, far, but and we are the only developed nation in this world who is not able to have a great national system of healthcare, and it's shame on us. So I think those are some of the things that talk to the policies that we all can talk to at the state level. For instance, with Medicaid, and I think we're going to see some of this with President Biden, women who, the number of births that are paid for by Medicaid, that are supported by Medicaid, is very large. But a woman has her child and then there is no postpartum care. It's usually for, I think it's like 6 weeks. So we need to extend that at least to a year. And I know that is one of the policies that President Biden has put on the table. So I would say policy is one way of getting to structure.
Okay, thank you, Iris. And you've talked about a lot of things that are needed. And one of the questions that came in was about reparations. Reparations is back in the national conversation again. And the question was, reparations to Black Americans has again been discussed. Could reparations be targeted to end disparities in healthcare for Black Americans?
I certainly think that would be something that we could consider. And I've seen just in the last couple of weeks, you're starting to see individual communities start to decide what they think is one step to reparation. I don't know that anyone has the true solution to it, but certainly I think, for instance, I think it's Evanston, Illinois, that decided to give like a $25,000 a bonus to African Americans in their community qualified to help them get housing. So I think it's the same type of thing. It's not the overall solution. It is one solution. If we say that we start with one step, that could be one way that communities could say, how do we have better healthcare? What is the way to, I guess I would say, compensate Black Americans for the tragedy of poor healthcare delivery, and just total neglect. Why not?
And because we talked about like possible first steps, but Yvonka, do you think that it's something that could happen soon? Is it something that's realistic to help move toward racial equity in healthcare?
And that was the whole thing, is that about 15 years ago, we started putting equity into everything. Okay, we want to put equity in all policies. Well, for me, I think it's important for us to put reparations in all policies, and that way our children's children will still make sure that there is a reparations lens for them. So we have to have reparations in all policies.
Yeah, because if you think about what equity means, right? Reparation would be exactly the highest level of demonstration of equity.
Now there's a question here about people of color getting into the nursing industry, and particularly Black men. Dr. Hickman, do we see Black men going into the nursing industry, nursing profession, to help with some of the things you were talking about in terms of bringing more diversity into that profession to help with more equity?
So Marlene, to answer your question directly, no, we don't see the uptake in Black men becoming in nursing. I do see the uptick in white males going into nursing across the lifespan because it is economical. They can find jobs, there's a shortage and there's good pay. But we have a road to travel to convince Black men that nursing is a profession that is a noble and good profession for them.
What do you think the barrier is there?
I think there have been his historical roles. I alluded to some of the sort of structural and maybe institutional practices that have denied people of color for entry. I think, just to be honest, there's, very few of me in institutions of higher education and in nursing schools. And I think we definitely need to move that needle to be more inclusive. But until we get there, we've got to start upstream, introducing the idea to our young people that nursing is a viable career, and dispelling some of the myths and maybe the stigma that is around men in nursing.
Okay. So we have a question about racism as a public health crisis. How can we get people to see this as a human and a civil rights issue and not a political issue? How can we divorce this conversation from politics? Or is that possible?
All right, I'm going to try this. So there's a question that was raised that I want to read the words to, if I may. Marlene, is that okay?
Absolutely.
My state, this is from a participant. My state senator is a physician, yet he asked aloud if Blacks were more likely to get COVID due to poor health habits like lack of hand washing. He also referred to African Americans as colored people. He has moved up in the state legislature over time. This happened this year. This
I
isn't
remember
many
that.
years
Yeah.
ago,
Yeah.
right? So when we start talking about how do we pull this issue out of the politics of where we are right now, I think it's going to be a long haul to do that. And when you see this kind of entrenched attitude, you have to know that we have a long way to go. And so I grew up in Lima, which is where the senator actually covers. I know what my dad meant when he used the word colored. There's no doubt in my mind. This was a slip, an unfiltered thing that happened, but that's how people talk in that neck of the woods. So our work is really, it's got to be persistent. It's got to be day to day. And your question was exactly right. It also has to reach into our churches. It has to reach into our social institutions and begin doing what Yvonka is doing and gathering people together to have these conversations about how we move this forward.
Well, somebody touched on this earlier, but there was a question that came in about, should healthcare for all be designated as a right for all Americans? I think Iris might have brought that up in terms of how far we went with Obamacare. Dr. Modlin, what do you think? Should healthcare be designated as a right for all Americans?
Absolutely. I mean, I think it's a human right that we all have an opportunity to achieve the best healthcare status that is possible. And one way in which to do that is to undergo routine preventative health screenings. Again, a lot of the disease states that I talked about, a lot of the cancers and high blood pressure, heart disease, for example, you don't have to have any signs or symptoms. By the time a urologist or primary care physician performs a prostate exam on a man and fills an abnormal prostate, 50% or more of those are already metastatic, advanced. So the best way to diagnose prostate cancer, for example, is through a routine blood test, a PSA, routine preventative health screening. So it is a human right that everybody should have access to quality healthcare. And there are differences in the quality of healthcare that people receive, even when they do have access. So absolutely, we need to move to a situation where everybody actually has access.
Does somebody else want to weigh in on that?
I definitely think it's a human right. I'd like to give a call out to our League of Women Voters, to our conversation about how do we make change. And I think our right to vote is an incredible mechanism for making change. And that right to vote is constantly being challenged, but we need to challenge back. And I think it's important. We think of it at the state level and we think at it the federal level, but we also have to think of it at the very local level. I mean, it's prosecutors and police organizations that make the difference every day. And so I think we need to think about how we can start growing our community members to decide to run for office, how we support them, and how we start changing the composition of our local governments as well as state and the national.
So Iris, I say it this way. There used to be a store in Cleveland, in Northeast Ohio, that was called Sims. And Sims' slogan was, the educated consumer is our best customer. And for us, the educated voter,
yes,
is our best community advocate, because we have to stop voting the ticket. We have to make sure that people have our best interest and the best interests of the community, and that we're not letting other people pick who our leadership should be. And that is so important. That is something that we have to relearn, because we did that because of illiteracy, and now we are literate enough to go into that box and pick out the best people
That's right.
with the best ideas for our community to help uplift us out of this.
Yeah.
Yeah, it sounds like you guys are saying we can't divorce it from politics. That politics
You
is
can't.
all in the middle of this, all up in it. Okay, let's talk about COVID-19 for a few minutes. Because COVID-19 has put a spotlight on health disparities. So what are the lessons that we've learned during this pandemic? Is there a movement toward mitigating these health disparities that have come up during COVID-19?
As a person who is struggling with COVID-19 as a long hauler, we haven't learned a doggone thing. We talked about this glaring light that COVID shed on all these inequities in our community, around testing, around access, and now we have the same thing going on with the vaccination. And so do you understand that the light is still there? And I don't think that we have put enough emphasis on the fact that the things that happened with COVID, around African Americans losing their lives disproportionately. I've lost 35 high school friends, graduated in 1986. 35 friends have died from COVID. 63 days ago, I was going to die. I went to the hospital because two of my friends who are researchers said, we want you to go to this particular hospital. Don't go to the hospital in your community. And we need you to request this drug. And we need you to not leave until they give you the drug. And they gave me an experimental drug, belamimab. Dr. Maudlin knows what I'm talking about. Dr. Hickman knows what I'm talking about. It is the same drug that Donald Trump, Chris Christie, Ben Carson, that they all took. That drug saved my life. But
so because you had that access.
But when I read about the drug, I found out that 300,000 units of that drug was put not into the urban community that was most disproportionately impacted by COVID, but in rural communities. So rural communities were getting a drug that urban community needed to save their lives. So I just don't think that we have got it. I don't think that we have got it.
And quickly, what about the vaccine hesitancy issue? We keep hearing that there's hesitancy in the African American community. Is that true? Is it more than other communities?
Yeah, we actually have seen a relative hesitancy in African Americans to accept and get the vaccine, but actually that is changing in national surveys. Back in October, only 43% of African Americans were willing, and the survey in January showed that about 61% of African Americans were willing to get the COVID-19 vaccinations. One thing I think we need to remember is why there is reluctancy and hesitancy. A lot of it is, the distrust of the healthcare system, Tuskegee syphilis experiment, many of the history that Yvonka Hall actually enumerated. Some of that I wasn't even aware of. So we have to keep that in mind. We're actually living in a post-traumatic stress syndrome disorder state in many respects. And I think we need to understand that it affects the way that our willingness actually to access the healthcare system. And there are a lot of misconceptions out there. We as Black physicians, healthcare providers, need to be a resource to direct people to the right information about the COVID-19 vaccines.
Sure.
So we're just about out of time. Can we go around and each panelist just give a quick final thought, about a minute at the most? Let's start with you, David.
Stay in the fight. It's a long one, and we need every one of your faces in it. It's important that we do what we're doing and that we keep this conversation going. Thank you. Thank you, Marlene. You did a great job tonight.
Oh, thank you so much. Yvonka, you're up next. What's your final thoughts tonight?
So my final thought is that in order for us to make sure that we have healthcare and access, that we have to prioritize the issues that are going on in the African American community, and understand that at 87%, is something that still impacts us today, and will impact us for the remainder of our days here. So we have to understand our communities that we seek to serve.
Thank you so much, Yvonka. Iris.
I'm going to take a moment to do a shout out and say that, it has to be community engagement and collaboration. And I know, access, while we're having more people uptake on the vaccine in Akron, for instance, we have an access issue, and organizations like the NAACP are working to make sure that we have other organizations that are in our communities and conveniently providing it. I think we'll see an uptake on that. So I want to thank Judy for that type of work, because it is stepping up that makes the difference.
Thank you so much, Iris. Dr. Hickman, your final thoughts.
So my final thoughts, I think I want to end with two. First, nurses are in communities, they are connected, and they are great connectors between social services, medicine, and other providers. And so I think, we've certainly seen in this pandemic a need for the investment in infrastructure, in data, and science. And I want all of our healthcare professionals to play their part.
And Dr. Modlin, you get to round us out.
No, I mean, I'll just say that each one of us, everybody in society, can actually play a role to addressing and eliminating these healthcare disparities. I think we need to have a better appreciation of the contribution that the social determinants of health play in terms of contributing to these healthcare disparities. It is about collaboration, community outreach, partnership, and education, and providing people with the appropriate information. And hopefully we're going to improve healthcare access for all.
Wonderful. Thank you so much, panel. You guys have been awesome. But we're not done yet, though. We're going to talk about action steps that people can take, right? So I'm going to turn it over to Sally Saltzman, the Diversity Programming Chair at the League of Women Voters in Kent. And Sally's going to walk us through some actions that people can take right now to address racism and the public health crisis, and also share some additional resources. Sally.
Thank you so much, Marlene. Now that you've learned about racism as a cause of health equity disparity, what can you do to ensure all citizens have access to quality health care? To make real changes to address this disparity, we must use the health equity lens on all public policy and legislation, whether at the federal, state, county, or local level. The League of Women Voters of Ohio position on health equity calls for legislation that would act as a means of assessing all proposed legislation as to its impact on health equities prior to adoption. HCR 6 and SCR 4 correspond with the League's position. Please click on the link in the chat box to immediately send a message to your legislatures to let them know you support HCR 6 and SCR 4. And now a few words about virtual testimony. The fight for all voices to be heard in our democracy is not over. Whether due to physical health constraints, work obligations, logistical challenges, or family responsibility, there are voices not heard in the Ohio State House. For these reasons, the League of Women Voters is among many organizations calling for virtual testimony at all state legislative hearings. If 2020 taught us anything, it is that the country can operate effectively in a virtual environment. The Ohio State House can too. If you want all Ohioans to be able to exercise their rights and take part in the policy-making process, click on the link in the chat box to send a message to your legislature to let them know you support virtual testimony. And finally, a few words about the League of Women Voters and our partners. Has the Real Talk series inspired you to get involved in ensuring equity, civil rights, democracy are realized for all Americans? Consider joining the League of Women Voters and our incredible program partners. Tonight's program was hosted by the Akron, Greater Cleveland, Hudson, and Kent Leagues in partnership with the Akron NAACP, Case Western Reserve University, the Freedom Bloc, ideastream, the Northeast Ohio Black Health Coalition, Ohio Public Health Association, Planned Parenthood of Greater Ohio, and WKSU. Visit these websites for more information about who we are, what we do, and how you can get involved. Thank you to Marlene Harris-Taylor, all of our fabulous panelists, and you for being part of tonight's program. Thank you and good night.
Thank you so much, Sally. Thanks to everyone who's watched tonight. We've got to stay engaged. We've got to keep talking about this. So share this conversation with everyone you know. And remember that all of tonight's information is available on the Real Talk website, which is www.realtalklwv.org. Good night. Have a great evening.